Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Have you ever considered how childhood adversities may shape your mind or your life? An international team of psychiatrists has, and they published their research in the journal Psychiatry Research. Here to tell us about their work is Dr. Thomas Schulze. He's a professor of psychiatry and behavioral sciences at Upstate and president-elect of the World Psychiatric Association, a group representing 147 psychiatric societies in 123 countries. Welcome back to The Informed Patient, Dr. Schulze.
Well, thanks for having me. It's a pleasure.
Well, can you start by explaining this study, which involved many psychiatric researchers from several different countries?
Yeah, I'm happy to do so. And first of all, I would like to say that this is a multi-researcher, multi-site study, as you pointed out, and it was basically carried out at sites in Germany and Austria, where I have spearheaded over the past 15 years now a large multi-site, multi-center study at 20 sites or so. This study, again, we started in 2012 or so, has some unique features. And these unique features are, it is a longitudinal study. So we have established a cohort of patients who we followed over time. So it's not just a one-off thing. It's not just like cross-sectional, as we call it. It's perspective. Yeah, over a certain period of time, it's not that long. It's 2 years, but we saw them at 4 time points. And so we could assess how their illness evolved, how medications may be helped, how environment impacted on their current situation. So it's a longitudinal study. This study is called PsyCourse. And I would like to thank all these people and people who actually were responsible for writing the paper. I'm the guy who designed the study in the first place. This particular study was written and was spearheaded by folks that I work with.
So what was the premise that you started with?
Again, while we talk about childhood adversities here today, and we'll go into that, this study was not designed to study this only or specifically. This cohort was established to create a resource that for many years to come will put us in a position to answer questions like the one we are just discussing today. This is about assessing the impact of childhood adversities in one's lifetime, in one's past history, on one's current symptoms, on one's current outcome, these aspects. That's what we did. And the term that we use is childhood adversity or adverse childhood events, ACEs. So this is what the study was about, because we have known for quite some time there's a connection between ACEs and mental illness, and he wanted to shed some light on the specifics of this relationship.
So what counts as an adverse childhood event?
I think everybody may have some concept of this. Here, of course, in a study, you have to define it, and we defined it by using a special tool, which is called a childhood trauma screener, which is actually a tool that was developed based on something called the childhood trauma questionnaire, which you give patients and you ask about, their experience in childhood. Here in this study, because we have like 2,000 variables for time points or asked at each time point, you cannot always get the maximum. You have to compromise. And so we use the screener tool, which screens the most important childhood adverse events, which are like five that are really of importance, like physical neglect, physical abuse, emotional neglect and emotional abuse, and sexual abuse. So these 5 domains or adverse events, these are captured by this questionnaire, which of course is a retrospective assessment, because you ask people who are already adults or young adults, and we ask them about what happened in their childhood.
And these were people from Austria, Germany. How many people are we talking about?
I think, 20 sites from northern Germany, like central Germany, and southern Germany, and one site in Austria. This is a study, again, that where we recruited patients between 2012 and 2019. And we also recruited 300 people who would not identify as having a psychiatric disorder. So that's what you consider a control group. So there were roughly 1,700 persons, 300 of them not identified as patients. So 1,700, like 500 people with schizophrenia, 500 with bipolar disorders, 300 with depression, or 400, and the remainder being these control individuals, and followed over time at 6 months intervals, 0 at baseline, 6 months, 12 months, and 18 months. And that was done at these centers in Germany and one center in Austria.
If I understand correctly, you found that quality of life was significantly affected by adverse childhood experiences, particularly emotional neglect. Why do you think that is?
That's correct. So I think, again, we have known for quite some time that adverse events are contributing factors to mental issues, mental illness, psychiatric disorders, disturbances, and so forth. Here we wanted to dig a little bit deeper and to kind of dissect what the relationship is really about. So we focused on things like quality of life, which is something that is assessed by also a certain questionnaire. Quality of life is something that hasn't really been in the focus of psychiatry. People don't have really time to assess this, but I think it's a very important matter in an individual's perception of their position in life, in the context of the culture and value systems in which they live, in relation to their goals, expectations, and so forth. So this goes well beyond, above and beyond just being free of symptoms or being low on symptoms, because I think this is a very important concept. As psychiatrists, as doctors, we typically try to get rid of the bad mood or the low mood or the high mood, the extremely high mood, the manic mood, the psychotic events, and so forth. But maybe someone actually might even have psychotic features, might experience some delusions, but may say, well, actually, doctor, this doesn't really bother me. But what really bothers me is that my quality of life, that's really bad. And that's why I think psychiatrists should focus more on that. And so what we found now, we looked at this, and as you pointed out, it is that emotional neglect had an impact on quality of life much later in life.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Upstate psychiatrist Thomas Schulze about the long-term impact of adverse childhood experiences. You also found that depression symptoms were significantly associated with adverse childhood events, especially with emotional abuse. What counts as emotional abuse as opposed to emotional neglect?
What is emotional neglect? Emotional neglect is when, let's say, a child's emotional needs for love, support, and validation are not adequately met by their caregivers, by their parents, by whoever is tasked with raising them. So when they do not receive this at all, this is kind of a passive adverse events. Then the emotional abuse is any kind of abuse that is not physical, but that is meant, let's say, to control, isolate, or frighten you. I think many people can relate to that. It can happen in romantic relationships, it can be threats, insults. You can be checking on someone, monitoring on someone. You can be excessively jealous and maybe try to manipulate. All these new words like gaslighting and ghosting and all these things, humiliate people, intimidate. And of course, when that happens in a relationship between a parent and the child, for instance, that is even worse. So again, this is emotional abuse. The other one is emotional neglect. Neglect is basically the passive, and abuse is the active childhood adverse event in terms of emotions.
Now, the conclusion about adverse childhood experiences influencing the severity of affective or psychotic disorders,
right,
that should be considered when evaluating and treating patients. So how might treatment change if the patient had adverse childhood events?
I think I still owe you the answer to the first question, which is we analyze this sample this cohort, altogether, we had data on 725 out of these 1,700 had full data, and they had data on the childhood trauma screener. So we had data on them. So what we basically saw is that there's a substantial burden, as you said, of emotional use and neglect, and it correlates with depressive symptoms because we did it across disorders, schizophrenia, depression, and bipolar disorder. And even in schizophrenia, there are depressive symptoms. So what we can see is that there's this strong correlation between someone having had this in the past, had these symptoms in the past in his life, and current depressive symptomatology or psychotic symptomatology. How can we use that information? I think what is very important nowadays, we are under time constraints. Just try to get an appointment. It's hard to get an appointment, right? So now when you have an appointment, you focus on the symptoms, you focus on what you have right now. And then the doctor might give you a medication or whatever, or if you are lucky, you will have more time to really assess what happened in your life. This may happen over the course of time. So now when you find out that there is something in terms of abuse, neglect, this is an important factor that may help, that may actually maintain symptoms. So maybe you treat something, but there's something never really talked about. There's something that is somewhere simmering. And these symptoms, if they're not addressed, they will always be there. They have never been talked about. And so this is continuous chronic liability. So you can maybe treat some symptoms, but the chance of recurrence is very high because this is not addressed. So I think what our study highlights is that quality of life, current symptomatology is influenced by things that happened in the past. And even though you may treat current symptoms, you may not fully be able to treat them because there's something that is always coming up. It's like considered like a chronic infection. You can treat maybe the fever, but if it's still there in the body, like a sepsis, then it will never go away. So this is, I think, the important message here.
Well, for adults who are listening who had an adversity in childhood, can they take anything away from this study?
I think what they can take away from the study is that they may sit down and just take some time and think about, hey, okay, I have this depression now and I've been seen by doctors, psychologists, whatever, and I take these pills. Yeah, they kind of help me, but isn't there something else? Wasn't there something? And maybe they already know it, but maybe they should look closer to that. But I think it's very hard. So that's where you actually need the doctor. That's where you need the psychiatrist, psychologist, the psychotherapist. And if they take their job seriously, they should at one point address these issues or ask, you know what, all what you described could also be triggered, or there could be a root cause, or not a cause, but it could be a contributing factor. And they should bring this up, but not something that you bring up in the first visit, because there's a lot of shame maybe attached to it. There's a lot of fear. And some of these things are, well, I don't like to use the word unconscious. I'm not a psychoanalyst, but of course, there are some things that we sometimes don't want to realize, that we don't want to talk about. It's hidden. So it takes a good doctor-patient relationship that has developed over time to talk about these things. So at the first visit, you focus definitely on maybe your life. What do you do for a living? Blah, blah, blah. Family. Okay. What are your symptoms? Okay. Then once you have developed a good relationship, then these things can be addressed. Even in the study we did, that the childhood trauma screen that we did, we only did at the third interview because we didn't want to overburden them. We didn't want to frighten them. So it is something that needs some time. The patient needs to open up. Maybe the doctor needs to open up. You can only assess this in a certain atmosphere. So I would say it's not only the patient that I would give advice, it's the doctor that I would give advice to. The doctor-patient pair, this is the group that this study gives advice to.
So the doctor really needs to keep this as a consideration, something to bring up at some point. And the patient also needs to sort of reflect on their past and bring that up in therapy as well.
Absolutely. And again, it's teamwork. Sometimes there are patients who, after having had depressive episodes for 20, 30 years, and they are doing so, well, they can work and everything, but they're never really fully recovered. And they will always have recurrent episodes. And maybe at one point, after many years, they find the right therapist, find the right doctor, and they have the right partner who says, wait a minute, didn't you tell me about this? So it's also something that your partner has a sort of a responsibility. Wait a minute, what did you just tell me? You told me about this. Maybe you should address that. You don't have to talk to me about it, but maybe you want to discuss this with your therapist. So I think everybody that is around the patient in question has a certain responsibility also to not intrude here, but maybe suggest that if there's something, hey, have it checked out and discuss it with someone, the professional.
Do you ever see people who had adverse childhoods, but who have managed to thrive in adulthood? Because I'm wondering what we can learn from them.
Oh, sure. I mean, that's the word resilience, right? The term resilience. You just have to look at all the survivors of the Holocaust as a famous example, or survivors of trauma situations, of horrible trauma situations. Well, these are, of course, the extremes, right? But yes, of course, you will find people who, when you dig deep, who will have had a horrible experience, adverse events during childhood, and who came out beautiful, who came out healthy and strong, who may have had depression or whatever, but who have overcome it. And then you have others who have maybe something that is more what you think is minor, but still suffer. There's no way that you can scale it. You cannot say, hey, this is really nothing compared to what this person has. Please, come on, just move on with your life. Well, we can't do this because everyone's different. Yes, of course, we will see patients, and maybe then we can ask these patients, what helped you? As a doctor, you may even learn from that. But, it's so highly individual. There is no boilerplate approach to that. But these people exist, which is great. But it doesn't mean that there is kind of a recipe for success here. You cannot say, hey, I'll just interview that survivor of that major trauma. Here we have 1, 2, 3, and 4, and everyone can do that. No, that's not how it works. It's very individual, and something that is little for someone, just something little, may be a big thing for someone else.
Well, your work is very interesting, and I appreciate you taking time to share it with us.
Oh, sure. It's always a pleasure.
My guest has been Dr. Thomas Schulze, a professor of psychiatry and behavioral sciences at Upstate and president-elect of the World Psychiatric Association. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.